Good evening, everyone. Tamir Bloom. I'm a pediatric orthopedic surgeon, and I'm going to be talking about club feet and Metatarsus Adductus, two very common foot deformities that we treat. I'd like to thank Dr. Dean and Dr. Wittig for the invitation to present to you today. So most of the presentation will be focused on club feet, as this is a much more complex and involved in terms of management condition as opposed to Metatarsus Adductus. So hopefully I'll address some of the common questions that the pediatricians have out there. So what is a clubfoot, also known as Talipes Equinovarus? Talipes is Latin for ankle and foot, and Equinovarus describes two of the four deformities of a clubfoot. Equinus, which is plantar flexion of the foot relative to the leg. Varus, which is the hindfoot medial deviation relative to the leg. Forefoot adductus, which is medial deviation of the forefoot relative to the hindfoot. And cavus, which is plantar flexion of the great toe, or the lateral ray, or sorry, medial ray of the foot relative to the hindfoot. So if you guys are able to recognize those four deformities, then you can diagnose a club foot. So club feet are quite common, about 1 in 1,000. In some populations, it can be a bit higher, 1 in 250. They're a bit more common in boys. They can be bilateral and up to 50% of the time. They are congenital. This is a diagnosis that you can make in a newborn. And they range in severity from being very stiff to not so stiff. So we'll talk a little bit about that later. The inheritance is multifactorial. We know that in terms of the etiology, they're probably a combination of genetic and environmental factors. We know this from twin studies, as well as some of the genes that have been associated with club feet have been described. Some of the environmental risk factors include maternal history of smoking during gestation, maternal obesity, gestational diabetes, as well as use of SSRIs during pregnancy. As we'll see, there are some neuromuscular conditions that are associated with club feet, and so this has led to a neuromuscular etiology during fetal development as the etiology of clubfoot. But the exact etiology is unknown. What we do know that it is not due to intrauterine molding. Some of the conditions we talked about, like torticollis, as well as Metatarsus adductus, are associated with the intrauterine molding, but not club feet. So what is the pathoanatomy? Essentially, all the musculoskeletal elements from the leg down to the toes are involved, including the bones and the joints, which are dysplastic, and the joints are malaligned, particularly in the ankle and in the hindfoot. Both the ligaments and capsules are contracted, and this suggests suggestive of some of the fibroproliferative disorders that we see, such as Dupuytren's contractures. There's atrophy and abnormal muscle fibers in the muscles of the leg, and there are also associated vascular abnormalities. This is truly a complex deformity. This is the natural history. You saw the natural history of torticollis, but this is a deformity that persists, and if not corrected, as in this child and this probably young adult, results in significant morbidity and significantly affects quality of life. There are a number of different classifications for club feet, but probably the most common one I can simplify into basically idiopathic club feet, which are club feet that are otherwise found in healthy, normal babies or children, and those make up the vast majority of club feet that we see. There is a sub category of atypical or club complex idiopathic club feet that tend to be a such thing as a postural or position clubfoot, which is a clubfoot, which is a foot that looks like a clubfoot, but what separates it from a true clubfoot is its flexibility. And then there is a small percentage of club feet that are found in syndromic and neurogenic conditions. And this is just a picture of a 3-week-old that was born here and just recently started treatment for her club feet. So what are these associated neuromuscular conditions that we should always look for? These include, there's an arrow here. There you go. This is a child with knee flexion contractures. This is arthrogryposis. This is an infant with a knee dislocation. This child has Larsen syndrome, and you can see the clubfoot here. And this is a child, unfortunately, cut off the feet, but you can see missing digits. And this child has Streeter syndrome or amniotic band syndrome. So we always want to think about these conditions. How about the diagnosis of club feet? This is a clinical diagnosis, and what we want to do during our clinical exam is basically look, feel, and move the foot. What are we looking for? We're looking for the size. The clubfoot's always going to be a bit smaller, so if you have a unilateral clubfoot, the foot's always going to be a little smaller than the normal foot. The calf is always going to be a bit smaller in width as well. And the child is going to have skin creases on the medial side of the foot as well as in the back of the hind foot, as you can see here. The foot is going to feel stiff. It's not going to move that well, particularly in dorsiflexion. Okay? In a true club foot, you're not going to be able to dorsiflex the foot up to or beyond neutral. We move the foot to see if it's passively correctable. Again, this is going to help us differentiate it from a postural club foot. And then we want to examine the entire infant or child, again, to rule out neurologic or syndromic causes such as spina bifida. Unlike Metatarsus Adductus, a clubfoot is not a risk factor for hip dysplasia. So if you diagnose a clubfoot, it is not recommended to get, or I should say, it's not necessary to obtain a hip ultrasound in an infant. But ultrasound is available for diagnosis of a clubfoot prenatally. It is pretty accurate, up to 83%. Although the false positive rate varies from 10 up to 30%. We can typically diagnose a clubfoot, as you can see here, about 27 weeks or 30 weeks. The older the fetus, the more accurate the diagnosis. The prenatal diagnosis helps us to rule out any associated anomalies, and I think most importantly gives the family a time to understand the condition and get prepared for the treatment. And in fact, most mothers who've had infants with club feet prefer to have the prenatal diagnosis based on studies listed over here. I think the world owes a debt of gratitude to this gentleman who unfortunately passed away a few years ago. This is Ignacio Ponseti, and he developed the Ponseti method, which is the gold standard for current treatment of club feet worldwide. The Ponseti method involves three basic steps. The first one is a series of castings. Usually these are plaster casts from groin to toe, and the casts are placed on every 5 to 7 days. The foot prior to casting is manipulated due to, using a technique described on Ponseti, and then after the foot is corrected, as you can see here, this is perhaps the final cast. We move on to step 2, and here's the newborn that I mentioned earlier. This is the first cast, 3 weeks of age. The step 2 of the Ponseti technique involves a percutaneous tendo-Achilles tenotomy. This is not a lengthening, this is tenotomy. You want to cut the tendon completely. This can be done in the OR as shown here, or in good hands in the office. The tenotomy is followed by a cast that's put on for 3 weeks, And then we move on to step 3, which is a brace. This is a foot abduction or orthosis that holds the foot corrected. The first 3 months it is worn 23 hours a day, and then the infant is weaned nighttime. And Ponseti recommended wearing the brace till upwards of 5 years of age. So this is a long-term commitment. The involved foot is usually abducted a bit more than the uninvolved foot, as you can see here. The Ponseti technique, when correctly applied and with good patient compliance, has excellent results and achieves correction in greater than 95% of patients. Ponseti's own data from Iowa, which is on average 3 decades of follow-up, found nearly 80% excellent to good results in terms of pain and function, compared to 95% in the normal population, which is not statistically significant. One of the important factors that Ponseti also noted was that children who ended up needing surgery had a much lower outcome score, 43%. Another important question I get from parents: does Ponseti treatment delay early gross development? And the answer to that is has not found to be the case. It may delay certain milestones by 1 to 3 months, such as walking, but it is not found to significantly impair motor development, except in case of surgery, which is rarely required in less than a year of age, not counting the percutaneous tenotomy as a surgery. This is more of a procedure. And kids with neurodevelopmental difficulties tend to have some impairments, as opposed to kids who otherwise do not have these difficulties. How about when should we start the Ponseti treatment? When should we start casting? Ponseti showed, and multiple investigators have showed, that you have a couple of months. Certainly, we don't wait a few months. We start kind of as soon as the patient presents. You don't have to start in the newborn nursery. I think what's more important is educating the family and having them buy into the prolonged treatment duration. And probably what's more important than when you first start casting is when you stop the treatment. These children, as you'll see, need to be followed for at least a few years. Good results can even be achieved with the Ponseti treatment up to 2 years of age. Long-term follow-up is necessary because the main problem with Ponseti treatment is that there's prolonged treatment course, and the relapse can be high if there's loss to follow-up or there's any deviation from the Ponseti treatment methods. And this relapse may occur up to 10 years of age. The biggest risk factors that lead to relapse include noncompliance with the brace, as well as other factors that have been found, such as high school education or less, and stiffer feet, which tend to be the neuromuscular feet. In summary, for club feet, the treatment is long and involved, and I think what's most important initially when I see these children, either in the newborn nursery or when they come to our office, is developing a rapport with the family and explaining to them the prolonged duration of treatment. This is important in order for the family to be familiar with the Ponseti method. And the biggest, by far the biggest problems we have is compliance with the brace. So every time I see the family, I try to have a positive encouragement when they're doing a good job keeping their child in the brace. So just a little bit about Metatarsus Adductus. This is just a much less, or much more benign condition than club feet. This is a medial deviation of the forefoot relative to the hindfoot, as you can see here. If you look at the bottom of the foot, it'll look bean-shaped, and the lateral border will be curved. Here's a normal foot. Here's a Metatarsus Adductus. This is due to intrauterine positioning in a tight intrauterine space, and it may be associated with torticollis and hip dysplasia. I think if you see an instance like this, they certainly should have a hip clinical examination and possibly an ultrasound as well. This is incidence of Metatarsus Adductus is 1 in 100,000 and is bilateral 50 to 80% of the time. The management is usually gentle reassurance of the parents and observation, because about 95% of these will correct spontaneously by the age of 5. Occasionally, if these deformities are on the stiffer side, I will do a few casting to stretch them out, and Dr. Ponseti also described the correct maneuver to serially manipulate and cast Metatarsus Adductus. The casting is not that often needed, fortunately, and surgery is even rare. Here's a picture of an older child who had significant deformities, and you can see that this may affect shoe wear and cause skin irritation or cause pain in the foot, and these are indications for considering surgery. So two quite different conditions, both in etiology and natural history and outcome. And I'll leave it